Welcome to the deep dive. Today we're getting really specific, looking into a very technical piece of medical gear. It's something used in interventional gastroenterology.
Yeah, we're talking about a device that literally stops massive internal bleeding. Life-saving stuff.
And our source material today is pretty technical itself. It's drawn from lecture excerpts, actually, from Dr. Raju's YouTube channel. The video is called HCC 1472 Lesson 11A3 Hemostatic Devices Band Ligator.
That's right. And our goal here isn't just to, read the manual. We want to really unpack how this hemostatic band ligator works, how you set it up, and crucially, the safety steps involved.
Because messing up seems like not an option.
Definitely not. For anyone working in GI endoscopy, getting these details right is fundamental. It's about the procedure working and keeping the patient safe. Simple as that.
Okay, so let's start with the basics. What is this band ligator fundamentally?
At its heart, it's a hemostatic device. That just means its job is to stop bleeding.
And where does it mainly get used?
Primarily, variceal therapy. So treating or preventing bleeding from varices, those are fragile, enlarged veins, typically in the esophagus, often caused by serious liver disease.
Right, those can bleed massively.
Exactly. So clinicians use the band ligator either for prophylaxis, meaning they band risky varices before they rupture, or they use it in an emergency to treat active, really dangerous bleeding. It's a critical tool in those moments.
But the source material points out something else interesting. It's not just for bleeding.
No, and that's where it gets quite clever. It shows how doctors adapt these tools. There's a secondary use in tissue management.
Tissue management, how does that work?
Well, think about conditions like Barrett's esophagus, especially when there's high-grade dysplasia, which is like precancerous changes.
Yeah.
You can use the band ligator to actually capture that abnormal tissue. You place a band, it sucks the tissue in, creating a sort of pseudopolyp.
Ah, so you lift it up, make it easier to remove.
Precisely. The band constricts it tightly, making it simple to then resect or, cut away that specific bit of diseased tissue.
Wow, okay. So you're using the clamping mechanism not for bleeding, but to isolate tissue for removal. That's quite adaptable.
It really is. It allows for what's called localized mucosal resection. And the source mentions this isn't just limited to the esophagus. You could potentially use it elsewhere in the GI tract where appropriate. It turns a bleeding stopper into a tissue removal aid.
Very versatile then. But, okay, before any of that happens, someone needs to assemble this thing. And it sounds like the setup is complex.
It requires attention to detail, absolutely. When you open the kit, you get basically four main things. The control handle itself, a loading catheter, the cap, which is preloaded with the bands and has this thin tripwire attached, and an irrigation adapter.
And you mentioned the control handle is key.
Absolutely central. Understanding the handle is probably the most critical part of the whole setup. It's where things can go wrong if you're not careful.
Why is that? Is it like a safety switch?
Kind of, yeah. That's a good way to think about it. The source highlights two really distinct positions for the control knob, and mixing them up is dangerous.
Okay, what are they?
You've got the two-way position and the firing position. The two-way is your setup and safety mode. It lets the knob turn both clockwise and anti-clockwise. You need this flexibility for loading the device, threading the cord, getting everything ready.
Makes sense. And the firing position.
That's go time. Once you click it into the firing position, the handle only moves clockwise. And that single clockwise turn deploys a band.
Ah, okay. And going back once it's in firing mode?
Exactly. So knowing which mode you're in and when to be in each mode is fundamental.
Right. Let's walk through that setup then. It sounds a bit like threading a needle through the scope.
It sort of is, yeah. You start by puncturing the scope's seal with the irrigation adapter. Then you push the loading catheter, it's quite stiff, all the way through the scope's channel until it pops out the other end.
Okay, so the catheter is just a guide.
Purely a guide. Once it's through, you attach something called the trigger card, which is connected to that all-important trigger cord onto the end of the catheter.
And then you pull the catheter back out.
Exactly. You pull the loading catheter back towards you out of the scope. As it comes out, it pulls the trigger cord with it all the way through the scope's channel. So now you have the cord running from the cap end through the scope to the handle end. The catheter itself is discarded.
Clever. So the cord now connects the cap to the handle running inside the scope.
Precisely. Then you take the trigger card that's now at the handle end, you load it onto a specific notch on the control handle, making sure the little knot on the cord sits securely in its groove.
And all this time, the handle needs to be in that two-way position, right?
Absolutely critical. Must be in the two-way position. No tension on the cord yet. Once the card is anchored, you gently rotate the knob clockwise, just enough to wrap the trigger cord around the handle mechanism, taking up the slack.
Okay, getting it taut but not tight.
Right. Then the final step is attaching the part with the bands onto the very tip of the endoscope. And one last check. You might need to rotate the cap slightly just to make sure the trigger cords inside the cap line up with the scope's biopsy channel so the doctor has a clear view.
Okay, that's a lot of precise steps. Now let's get to the procedure itself. You mentioned the danger of mixing up the handle positions. This seems like the most crucial safety point.
It really is. The source is emphatic about this. When the assistant, the tech or nurse, hands the assembled scope and band ligator over to the physician performing the procedure,
Yes.
that handle must be in the two-way position, non-negotiable.
Why is that so critical at that specific moment, the handover?
Because if it's handed over already in the firing position, that trigger cord is under tension. It's ready to go.
Ah.
And the source actually mentions cases, real instances, where just the act of inserting the scope, maybe a slight bump or maneuver, caused a band to fire accidentally
Oh, no.
into the patient's pharynx, or even hitting the uvula on the way down. Imagine that.
That sounds incredibly dangerous and traumatic.
Ah.
So the two-way position gives it some slack, prevents accidental firing during insertion.
Exactly that. It's a mechanical safety. It ensures there's no tension, no risk of premature deployment until the doctor deliberately decides it's time. It relies completely on the person setting it up, following the protocol.
Got it. So the doctor navigates the scope, gets near the target, the varix they need to band. What happens then?
Okay, now they're ready. They identify the target varix. First, they push the handle forward, clicking it into the firing position.
Point of no return.
Then, the key is suction. They position the cap right over the varix and apply suction, pulling the tissue firmly up into the cap.
So it fills the little cap at the end.
Yes, they need to ensure it's properly suctioned in. They verify the position visually, make sure they've got the right spot. Then, it's one smooth, deliberate, clockwise rotation of the handle.
And that single rotation does what?
That rotation pulls the trigger cord, which snaps one of the elastic bands off the cap and deploys it tightly around the base of the tissue that's been suctioned in.
Instantly clamping it off.
Instant mechanical hemostasis. Or, if they're doing the tissue removal thing, it strangulates the base of the targeted tissue.
Yeah.
It requires really good hand-eye coordination, especially under pressure if there's active bleeding.
Makes sense.
Uh-huh.
Now, beyond just the mechanics, the source talks about strategy. It's not random banding, is it? There's a logic to where you place the bands.
Absolutely, and this ties right back to the anatomy. Why do these varices form in the first place? Usually, it's from perforating veins, feeder veins, coming into the esophagus very close to the GE junction.
The gastroesophageal junction, where the esophagus meets the stomach.
Exactly. That's often where the pressure from the portal system finds its outlet.
So, logically, you need to start banding there.
Precisely. The recommendation, the standard practice, is to start banding at or very near the GE junction first. Deal with the source, essentially. Then you work your way upwards, sequentially. Start low, go high.
Okay, and do you just band everything or prioritize?
You definitely prioritize. You go for the highest risk varices first, the ones that look like they're about to pop.
And how do you tell which ones are high risk? What are the visual cues?
The source mentions specific things to look for what they call stigma of recent or impending bleeding. Big ones, obviously, so large size is a factor. But also specific signs like cherry red spots on the surface of the varix or something called the red whale sign.
Red whale sign.
Yeah, it looks, well, markings on a whale. These signs indicate that the vein wall is thin and under a lot of pressure. Those need immediate attention. Band those first before moving to less angry-looking ones.
Got it. And typically, how many bands get used in one go? Is there a standard number?
The device usually comes loaded with 6 bands, and the source suggests that typically applying up to 6 bands is the goal for one session. That should be enough to obliterate the main variceal columns causing the problem.
So I guess sometimes you might need more.
Potentially, yeah. In complex cases, or if someone needs retreatment later, maybe more are needed. But 6 is a common target for an initial, effective procedure.
Okay, this has been fascinating. It really highlights the incredible technical skill and the sheer precision needed for this procedure, from just unpacking the box to the final deployment.
It really does, and I think the key takeaways are definitely that critical difference between the handle's two-way position for setup and handover.
The safety mode.
Right. and the firing position for the actual deployment. Getting that wrong is just not an option.
And then tying that mechanical know-how to the clinical strategy, why starting at the GE junction is so important. It's not just random.
No, it directly addresses the underlying anatomy, the source of the pressure. It's where the technical side meets the medical understanding perfectly. It really shows you the level of coordination needed in modern GI procedures.
Definitely gives you a new appreciation.
And maybe a final thought to leave you with, building on what the source tells us. If these varices stem from those perforating veins near the GD junction, how does that specific sequence, starting low at the junction, banding upwards, how does that strategy not just stop immediate bleeding, but potentially reduce the chance of the varices coming back later on?
Because you're tackling the main inflow points first.
Exactly. It suggests the strategy is designed not just for the immediate crisis, but maybe for a more lasting solution too. Something to think about.